Continue on with Unit 4, Part 7, Objective 55, Select Medical and Nursing Care for Pregnant Women with Hyperemesis Gravidarum. This disorder is characterized by weight loss, electrolyte imbalances, which is usually the key hallmark of diagnosing it, nutritional deficiencies, and ketonuria. Risk factors for hyperemesis gravidarum include nulliparita, being overweight or obese, history of migraines, multiple gestation, molar pregnancies, and fetuses with chromosomal abnormalities. Nursing interventions is maintaining IV lines, monitoring for INO, fetal surveillance, including fetal heart rate, uterine contractions, keeping the patient in the MPO status, or offering them small, frequent, bland meals. And this is on page 349. The biggest difference between hyperemesis gravidarum and morning sickness is that hyperemesis gravidarum does have that electrolyte imbalance. Medical management of hyperemesis gravidarum, they may require enteral therapy such as TPN in order to get the nutrition that they need. We will be administering the antiemetics as ordered by the physician to keep their nausea and vomiting down. We may be giving them vitamin B6 and Unisom, which is paroxetine. And also herbal supplements such as ginger, chamomile, and raspberry leaf can be used to help decrease the nausea and vomiting. The main thing with hyperemesis gravidarum is that the nutritional deficiencies and electrolyte imbalances revert back to a normal state. Objective 56 and 57 is recognize common causes of bleeding during pregnancy and characterize medical management and nursing care of the pregnant client who experiences bleeding during pregnancy. Early pregnancy bleeding is usually caused from either spontaneous abortions, an incompetent cervix, ectopic pregnancies, or molar pregnancies. Late pregnancy bleeding is usually from placenta previas, abruptio placentae, or abruptions, or DIC, disseminated intravascular coagulation. What you see here in the pictures, on the top portions are placenta previas, and on the bottom portions are placental abruptions. With spontaneous abortions, there's 5 different types: a threatened, inevitable, incomplete, complete, and missed. This is figure 14.7 in your book. A is a threatened abortion, B is an inevitable abortion, C is an incomplete, D is a complete miscarriage, and E is a miscarriage. If you look at table 14.5, you can see the different types of miscarriages and their usual management. Threatened miscarriages, the main thing there is there's no passage of tissue, there's no cervical dilation, so the management is bed rest, sedation, avoidance of stress, and orgasm, avoidance of stress and orgasm, and further treatment depends on the woman's response to the initial treatment. In an inevitable abortion, there is no passage of tissue, but we have cervical dilation. Typically, the physician may choose to do a prompt termination of pregnancy by dilation and curettage. An incomplete miscarriage is that there is passage of some tissue and there is cervical dilation. Again, sometimes the incomplete miscarriage is completed by the use of dilation and curettage by the physician. A complete abortion is where all of the tissue has been passed and there's nothing left in the uterine cavity. A missed miscarriage is there's no passage of tissue, there's no cervical dilation. Typically, the physicians will monitor for this pregnancy to see if the miscarriage will happen on its own. If not, they will go in and terminate the pregnancy because the baby is no longer alive, and there is a risk of possible DIC and coagulation disorder or development if the pregnancy is allowed to stay in there. Your book also talks about aseptic and recurrent miscarriage. With recurrent miscarriages, it usually is defined as 3 or more miscarriages, and a prophylactic cerclage may be done if the premature cervical dilation is the cause. And we'll talk about that coming up here. An incompetent cervix is a painless, passive dilation of the cervix in the 2nd trimester. Management includes bed rest, potential use of pessaries, antibiotics, some anti-inflammatory drugs, progesterone supplements, and a cerclage. If you look at the figure on your right there, you can see what a cerclage is. It's typically placed between the 11th and 15th week of pregnancy, and it's basically suturing the cervix shut with permanent stitches. This can be removed after 37 weeks gestation or when spontaneous labor begins by the physician. An ectopic pregnancy. An ectopic pregnancy is a fertilized ovum outside of the uterine cavity, and you can see this in figure 14.9 in your book and 14.10. 95% of all ectopic pregnancies occur within the fallopian tubes. The classic signs and symptoms of ectopic pregnancy include a missed menstrual period. The patient will complain of abdominal pain, and the patient may have some vaginal spotting or full-out hemorrhage if the fallopian tube ruptures. Ectopic pregnancy treatment includes monitoring the HCG levels, doing a transvaginal ultrasound which will show the uterine cavity empty, additional lab work like a complete blood cell count, chem panel, coagulation studies, and there may be a possible blood transfusion that is needed. There are 3 courses of treatments that physicians can choose from depending on the gestation of the individual. First, they can do nothing and see if the baby will that's in the fallopian tube will reabsorb on its own. They may use methotrexate, and that's on the medication guide on page 357. Again, methotrexate is a chemotherapy drug, and what it does is it rapidly seeks out rapidly dividing balls of cells, and what the embryo is a rapidly dividing ball of cell, and destroy it. Or they can do laparoscopic surgery and remove the pregnancy through surgical techniques. Nursing interventions for an ectopic pregnancy include frequent vital signs, assessment of lung sounds and bowel sounds, start on IV and administer IV fluids and possible blood transfusion, administer antibiotics. We would give pain medications, maintain an NPO status preoperatively, possibly insert an indwelling urinary catheter, bed rest for an ectopic pregnancy prior to surgery, and early ambulation following. A molar pregnancy. And this is in figure 14.11 on page 359. Molar pregnancies develop when the chorionic villi abnormally increase and develop vesicles that resemble tiny little grapes. A complete molar pregnancy is where there's no fetus present, and a partial molar pregnancy is when only part of the placenta has that characteristic vesicles. Molar pregnancy can cause hemorrhage, clotting abnormalities, hypertension, and the later development of choriocarcinoma, which is huge. Chromosomal anomalies are very common in molar pregnancies. Signs and symptoms of molar pregnancies include bleeding ranging from spotting to hemorrhaging, rapid uterine growth greater than expected for gestational age, an absence of the fetal heartbeat, signs and symptoms of hyperemesis gravidarum because they have elevated HCG levels, pregnancy-induced hypertension or gestational hypertension, higher than expected level of HCG, and a snowstorm pattern on the ultrasound. Treatment and nursing care for hydratiform molar pregnancy, including a suction and curettage by the physician, following those HCG levels until they are 0 and then for at least 1 year. And they're looking for the development of choriocarcinoma, which is a cancer. Rogram for women who are Rh negative, and education that the patient should defer pregnancies for 1 year. Nursing care for patients that have had a molar pregnancy, it's the same as an ectopic pregnancy or an abortion. The nurse needs to instruct this patient on contraceptive options and stress the importance of follow-up care. Emotional support is huge because now they've had this pregnancy and now are not going to be able to get pregnant again for at least a year. If they do get pregnant within the year, the chorionic villi from the molar pregnancy respond to elevated HCG levels and will grow, and that can develop into choriocarcinoma. Placenta previa. Placenta previa is implantation of the placenta. This is a late bleeding disorder of later pregnancy. It's implantation of the placenta in the lower uterine segment in front of the presenting part of the fetus. Placenta previa usually present with painless vaginal bleeding. There are 3 main types, and that's in figure 14.3. The marginal placental previa, which is the placenta barely extends to the cervical os, a partial placenta previa, which it partially covers the cervical os, and a total placenta previa, where the placenta completely covers the cervical os. We can do a trial of labor with a marginal, but typically the partials and the totals do have to go to C-section. Specifically the totals. You can't deliver the placenta before the baby. Again, here they are again, just visual representation, very similar to figure 14.3 in your book. Marginal again, the placenta barely extends to the cervical os. Partial, it partially covers the cervical os. And complete, it completely covers the cervical os. And you can see here as the cervix opens and dilates during pregnancy, how bleeding would occur with that. And keep in mind that the blood flow in the placenta is 80% fetal in origin and 20% maternal in origin. Placental previa treatment depends on the degree and status of the fetus and the mother. The first thing is bed rest. Absolutely no vaginal exams, none, because you do not want to poke your finger through that placenta. You monitor for signs and symptoms of shock. A cesarean delivery should be done before the onset of labor if it's a total or partial placenta previa, and you assess for bleeding and blood loss. Remember that 1 gram of blood, weight of blood is equal to about 1 milliliter of blood loss. And so you can weigh chucks and you can weigh pads against their dry weight and estimate the amount of milliliters of blood loss. And that can be done on any emergency situation or on the regular general medical floor to quickly quantify the amount of blood that is lost.